Hello friends, today we are going to discuss about the cytokine storm. This was the also question which was asked in DRNB Critical Care exam June 2022. The term cytokine storm was first used in 1993 by Ferreira et al. To describe the graft versus host disease in setting of transplantation. Subsequently, the cytokine storm has been implicated in the causation of several viral infection, autoimmune and hematological disease, and adverse reaction to few drugs. When coronavirus 2019 pandemic, there has been renewed interest not only among the medical fraternity but in the lay public regarding this entity. So, what are the cytokines? The molecules that are communicate along the cells of the immune system are referred to as cytokines. Chemokines are the low molecular weight protein with powerful chemoattractant activity, which play a role in the immune cell recruitment during inflammation. So, what is cytokine storm? It is the excessive and uncontrolled release of inflammatory cytokines in the context of infectious and non-infectious diseases and the accompanying immunopathology and clinical consequences. An uncontrolled overproduction of soluble marker of inflammation, which in turn sustain the aberrant systemic inflammatory response. So major categories are infection associated, secondary HLH associated with viral infections such as EBV, cytomegalovirus, then acute respiratory distress syndrome associated with COVID-19, toxic shock syndrome, which is associated with staphylococcal and streptococcal infection, then autoimmune and autoinflammatory disease like systemic onset, juvenile idiopathic arthritis, Kawasaki disease, systemic lupus erythematosus. Note the macrophage activation syndrome is the term used to describe cytokine storm in the rheumatic disease. So, also it is associated with the malignancy, which is associated with HLA. Iatrogenic, that is CAR T cell therapy in patients with leukemia and lymphoma. So, what are the cytokine implicated in this syndrome? These are interleukin 1, 6, TNF alpha, and interferon gamma. It must be noted that predominant cytokine responsible for causing systemic inflammation and multi-organ dysfunction may be different based on the underlying condition. This may in turn guide the targeted anti-cytokine therapy in given patient. For example, interleukin 6 is believed to be the key mediator for cytokine storm in the COVID-19 and hence the role of tocilizumab anti-interleukin 6 monoclonal antibody. uh, emap, enap, uh, Emapalumab, that is anti-INF gamma monoclonal antibody, has been approved for the treatment of refractory HLH because interferon gamma is the key cytokine driving storm in the primary and secondary HLH. Now about the pathophysiology, several models and hypotheses exist that explain the pathogenesis of cytokine storm. That is super antigen therapy. T cells get activated only when specific antigen bound to MHC class II bind to the T cell receptor, resulting in the activation of specific clone of the T cell that proliferate and handle the particular antigen. However, certain bacteria produces the super antigen that bind to the TCR-VB region. This binding is non-specific and results in activation of massive number of T cells, resulting in massive outpouring of cytokine, which in turn causes cytokine storm syndrome, toxic shock syndrome, secondary to the staphylococcal or streptococcal infection. It is a classical example. Now, defect in cytolytic pathway. CD8 T cell and natural killer cell plays an important role in clearing intracellular infection in our body, that is viral infection. So this process involves the killing of infected cell by release perforin and the granzymes. A defect in this pathway results in massive production of the cytokine, which is often triggered by the viral infection causing HLH. Now, defect in the innate cell. Toll-like receptors, these are the pattern recognition receptor of the innate immune cell, and plays a pivotal role in the identification and clearance of pathogen. So, defect in the TLR signaling pathway can result in aberrant activation of immune system, causing cytokine shock syndrome. The immune deficiency. Patient with primary immune deficiencies fail to clear pathogen. Persistent infection trigger the cytokine release and cause HLH. For example, patient with X-linked lymphoproliferative syndrome develop HLH on exposure to EBV infection. Now, why cytokine storm in fever? It is interesting to note that though several individuals develop infection with virus, only few of them develop cytokine storm, implying host factor plays an important role. Defect in the TLR signaling pathway and cytolytic pathway are important determinant of risk of cytokine storm in given patient. Now the clinical feature. High grade fever is the consistent feature. This may be associated with features of systemic inflammatory response syndrome, that is tachycardia, tachypnea, poor peripheral perfusion, and hypotension. In certain situations, ARDS may be the prominent feature. In severe form, multi-organ dysfunction, including hepatic renal failure, it may ensure causing mortality if not intervened in the time. Differentiating cytokine storm, HLH, and sepsis is challenging as many of the clinical features overlap. In this context, the role of H is being discussed in the next section of this review. Now, the lab barcode. There is no single diagnostic test for cytokine storm or HH. By cytopenia, so by cytopenia and pancytopenia is often found. Liver dysfunction may be C. C-reactive protein is markedly elevated and reflected interleukin 6 mediated inflammation. Ferritin more than 10,000 is often diagnostic of HLH, while the degree of hyperferritinemia may vary in the other form of cytokine storm syndrome. Now, sepsis and cytokine storm. As previously discussed, it is often challenging to differentiate sepsis and cytokine storm in given clinical scenario. The use of H score may guide the clinician in such a scenario. The score more than 120 predicts the HLH in children with sensitivity of 100% and specificity of 80%. Now about diagnosis, one must suspect cytokine storm or HLH in patient in presence of ongoing fever, features of cells, evolving and worsening cytopenia, rising CRP and ferritin level. The measurement of interleukin 6 level has been used to guide therapy in few studies. Clinical feature and lab parameter, along with sensible application of H score, would help in arriving at timely diagnosis of cytokine storm syndrome. Now about therapy, we have to treat the underlying cause. In patients with infection-associated HLH, treating the underlying infection remains the cornerstone of the management. For example, Epstein-Barr virus associated HLH, injection of rituximab is the treatment of choice to clear EBV infection along with immunomodulation for HLH. In patients with genetic form of the HLH, bone marrow transplantation would be curative. Then immunomodulation. Immune dysregulation is the cause of cytokine storm. Hence, immunomodulation plays a key role in the treatment of cytokine storm syndrome. So first drug in the immunomodulation is steroid. Intravenous pulse methylprednisolone, that is 10 to 30 mg per kg per day for 3 to 5 days, followed by oral steroid, remains the treatment of choice in macrophage activating syndrome noted in rheumatic disease. Chemotherapy, that is dexamethasone, cyclosporine, etoposide, in severe form of the HH. Intravenous immunoglobulin is useful in some cases of infection associated with HH. Intravenous immunoglobulin, cytokine targeted syndrome. Tocilizumab, if interleukin 6 is the key pathogenic cytokine. For example, cytokine release syndrome due to CAR T-cell therapy in leukemia and ARDS in COVID-19. Thank you, guys.